Hello, everybody. Thank you very much. Oh, how are you doing? I am back on HBMA Live, and it is extremely, I should say, a very contented feeling because I'm talking to my fellow medical billers and coders across the people who are watching this from India. We have people who are watching this from Philippines, and I have my good friend Dr. Pariksith Singh. Dr. Pariksith Singh has over 25 years of healthcare experience working in Florida. He is a don of managed healthcare. I call him a don because he's a good friend. I can tell him anything I want. Today he was extremely busy because he was working on a huge deal where he is about to buy another managed care company or something which he's going to talk about. But for me, he's always a good friend and an elder brother. Dr. Singh, welcome to the show. Just to give you a little background about HBMA, Healthcare Business Management Association is one of the largest association for medical billers and coders in the United States. I've been associated with them for last 15 years. In this year, I was actually lucky to get selected for the board seat. So I am talking to you on behalf of HBMA, and welcome to the show. Thank you very much for accepting my offer and take out some time. And I know all of our conversations are always full of innovation, full of, it's thrilling. You always come up with new opportunities. So I thought that through this conversation today, we are going to talk about what are the opportunities exist in managed care market, in managed care settings, and for billers, for coders, for practice managers. I know you have been working on gap analytics. You have been working on MMR. You gave me a few other things. So let's start with the latest. Tell me something about what you're doing with the EDPS and reps. Start the conversation.
Okay. So you may, those who do fee for value, those who do Medicare Advantage billing may be already familiar with EDPS wraps, although it is surprising that a lot of our colleagues, whether doctors, whether administrators, whether HMO experts, people who work in HMOs, don't really understand what EDPS wraps is. So in 2017, CMS changed the way they look at the codes coming to them on their Medicare Advantage members and changed the way they reimburse the health plans based on those codes coming through. So in the old days, a physician getting capitation amount, suppose he saw a patient X and he saw him in January, he put diabetes. In March, he put PVD secondary to diabetes. Then August, he sees the patient and puts cirrhosis of the liver. And then last visit, CKD3, right? And so the old days, and then the doctor doesn't bill for it because, it's a waste of time. I'm getting my capitation money. I get my $50 per member per month. Why do I need to waste time and pay my billers and coders extra money for this? And billers and coders traditionally have not liked managed care billing either because there's no percentage of collections. Usually the ones we dealt with, they used to get a certain amount, $1.25, $1.50 per claim being sent. So they don't, they're not very excited about it. So neither the physician nor the billing team nor the coding team is very enthused about it. So they say, okay, forget it. Who wants to bill all this? What the health plans did was they would come and review the charts, take all these codes. So you'll have diabetes with peripheral DM2 with DM peripheral angiopathy. You're going to have cirrhosis of the liver, and you're going to have CKD3. They would lump them all, send CMS. These are the codes we had on this patient.
That was the old traditional method. I know.
That was the old method.
Managed care billing, all doctors used to pay by per encounter, dollar an encounter just to enter the data. They said, here is my code, 10 codes. Your billing team has to do is enter the data. We'll pay you $1 per claim.
Right. So CMS would get this and say, okay, these are the codes per HCC. This is the amount we fund, you have an MRA calculator, and that's based on that they give the premium to the health plan. Now CMS said, no, we want to see the encounters in which it is documented.
And this has when did this happen?
2017.
2017.
Yeah, and so look, we're talking 2021, right?
I don't know the full thing about it. So that's the whole
purpose discusses it.
That our whole you are right in front of hundreds of medical billers right there.
Yeah.
The perfect spot.
So 2017 health plans did not catch up. 25% of it became EDPS, weighted 25%. Next year, 50%. Next year, 75%. Next 2022, it'll be 100% EDPS.
So all managed care billing, it's not going to remain the same.
All Medicare Advantage, any Medicare plans, if I may use the word, plans include PPO, POS. It'll be completely EDPS, no wraps, which means every encounter, this patient whom I saw 4 times, patient X, diabetes, then PVD, secondary to diabetes, then CKD3, and then cirrhosis. Every encounter has to go to CMS. They'll take those diagnostic codes from that encounter, and only then will they pay. So if you have 2 encounters missing out of those 4, guess what happened? Your HCC score dropped, RAF score dropped by almost, at least on number of HCCs by 50%. And so what happened was, when we started looking in 2019, we said, okay, all the health plans know this already. Let's look at the EDPS and RAP scores on our patients. Well, guess what happened? RAP scores were higher and EDPS scores were lower, which means only one thing: the encounters are not going to CMS.
That's true. Standard.
So we call it 7 layers of leakage, 7 points of leakage. I write the diagnosis. The coder doesn't pick it up. The coder picks it up. The biller doesn't send it. The biller sends it. It goes to your clearinghouse. Clearinghouse drops it. Clearinghouse, it goes to the health plan. Health plan drops it. Health plan sends.
So they didn't have any kind of a. So when Medicare introduced this new system, they did not introduce it on their CMS template or CMS form.
Everything is there. Everything is there.
Just everybody's ignoring it.
Yeah, because change is so difficult for us, right?
Right.
And especially health plans, these are legacy organizations. They take a while to catch up. Now, the more progressive plans will catch up right away. It's the clunky systems that take a long time.
Mom and pop,
bureaucratic. Yeah. So we found this gap. So that means encounters were not going through. So we looked at all the encounters that CMS did not get. So we found these layers of leakage. And then when the health plan sends it to CMS, there are 3 more layers of leakage. First CMS accepts it, receives it. They give you a file that we received it. It's called MAO2 file, right?
It's called MAO2 file.
Yeah, MAO. And you can find all this stuff. Then if I may, there are MAO4, MAO3, all these files. Then they say, okay, we're going to accept it. We received it. Second report is we accept it. Third is we're going to pay you for it. And then they give you data. These are called MMR files, monthly membership report. And they have a model output report. This is how we are paying you. Who looks at it?
What is it called? Model output report.
MODR file, model output report. So nobody looks at it, right? Except crazy people who are geeks will start looking into that data. So when we looked at it in 2019, we found a whole bunch of codes missed. Mm-hmm. So all psychiatry codes, nobody sent it. All podiatry codes. And it's not, biller's fault. Mm-hmm. Physicians, if you have a regular visit, what is it called? Wellness check, right? A wellness check.
Right.
If I write my documentation, CMS doesn't accept it on wellness check. So your encounter for that code will not be accepted because it's a wellness check. So now you have to be aware of it and make sure these things are billed right. So when we found them, we almost found 7,000 codes. We sent them back.
7,000 codes.
7,000 HCC codes.
So that means it was all lost revenue, never captured correctly. Or even if it was captured, it was never reimbursed correctly.
Physician documented it. CMS did not receive it because it was encounter didn't get paid.
Who lost all of that revenue? I understand that you.
Both.
both. So as a
Health
managed
plan
care,
lost it and the physician lost it.
right?
Physician's premium is very low. Health plan's percentage, if it's a risk contract, health plan gets say 15% or 17% or 20%.
So they
But
lost.
we have reduced the premiums, the health plan will get less. So all we had to do was take all these codes, give it to the health plan. Health plan said, no, no, we can't handle it. Too much data for us. We said, okay, allow us to submit it directly. Okay, you'll allowed. We sent it to CMS directly. Here it is. These are the codes.
So
Guess
you
what?
created a bridge between yourself. How did you handle the data connection and
Well,
this?
that's technology for you, right? That's
I
where.
know. I want to learn about it. I want to understand what is it.
Yeah. So we are happy to teach, happy to share with
Uh-huh.
you.
So is it
So
is an innovative technology you guys
that's
built it
right.
in-house? Okay.
That's right.
So and Medicare allowed you to build something like that and
Well,
then
it's
talk to your technology, or
Medicare gives you the guideline. The Medicare will
they,
tell you this is the
they do.
interface. This is how you'll connect to us. Medicare is very helpful.
Okay. So Medicare gives you the bridge, it gives you the technology or an integration capabilities.
Yeah.
It's just you as a business process, you have to understand it and you have to build the bridge and to make this happen. How much money do you guys make for doctors in last 1 week? I was reading that article. I have the numbers.
You have the numbers. It's on
Yeah,
LinkedIn. I
yeah,
posted
it's
it.
a LinkedIn article. Oh my God. So your
It's a
doctors
case
must be,
study. It's a
yeah,
case study, but think of what it would do. If you are an expert in it, it would enhance your value significantly. If you are even capable of speaking this language, which you should, all of you should
right,
know this language,
right.
because in some form or the other, you
It's
are
a
going to
huge
do
opportunity for billers. It's a huge
great
opportunity
opportunity.
for
You should know more than, so
yes,
we realize we know more than the HMOs. Some HMOs, we know more than that, or more
right,
than them.
right,
So that's one aspect, EDPS wraps,
right.
where you have to track each encounter as it's going through. And
Mhm.
if there's a leakage, last year we found leakage, almost another 4,000 HCC codes because CMS did not get it. It bounced, it leaked either at the claims gateway or clearinghouse, right? Or from health plan to CMS. We found uh, one file that was sitting there, 8,000 encounters that was sitting, it didn't go through. Something happened, didn't go through and just sat there. Nobody looked at it. So denials have to be looked at. Just like you work your ARs on your fee for service,
Right.
you have to start
Same way.
looking at the denials. CMS does not accept this. CMS does not accept it. Why? Why are you not accepting it? Then you look at the codes. Oh, patient information is wrong. This code is wrong. This
What is the basis? How would so that means I mean, if let's say being a biller or being a management consultant or billing consultant, if somebody has to look at it, then he has to have a huge amount of understanding, reading these medical records, coding, and specifically the protocol set by Medicare and understanding, so is it a different kind of understanding or it's the same regular medical coding understanding which you have for fee for service would also work for fee for value?
the fundamentals are the same,
Uh-huh.
but there is a little difference in how fee for value is different from fee for service.
Right.
And fee for value, if you have done hospital billing, your case mix index affects your DRG.
Correct.
Think of this as a similar analogy. Here, the case mix index, if I may use the word, although we don't use the word, the RAF score is the equivalent to the case mix index. The RAF score will affect your overall premium for the whole year.
Right.
And if you don't send the codes and you lose the deadline, you're dead.
Yeah.
You
It's
lose
the
those.
same way, like you have timely filing limit. You have the timely filing limit, but Medicare, you have almost a year to file the claim.
Yes. So
That's a
actually,
huge opportunity, actually.
yeah,
That you also mentioned at some point that there is a new system called risk adjustment payment system. That's what you talked about, that what Medicare has introduced 3 years ago.
yeah.
And
RAPS was the old system. RAPS has changed to EDPS completely.
perhaps it has been converted into EDPS. Okay,
Right,
perfect.
right.
Now, tell me a little bit about, you have few technology companies, and one of the technological challenges you just mentioned that you were able to iron it out with Medicare, and that resulted into a huge amount of financial reimbursement or outcomes for your physicians. I know you have over 400 physicians in your group, so that itself is a huge opportunity for anybody who wants to. How open you are to discuss your challenges, problems, as a physician or as a owner of this huge group, large group, with different other medical billers, consultants, because that's where this talk is going. People are hearing you, they're listening you, they love your ideas, they want to work with your opportunity. So I want to see where is an entrepreneurial opportunities, new business opportunities for people like us, for vendors, for billers.
I think there are two, three things, and we are happy to share with you. I mean, look, we write these books, and this is not. I just realized we have them here. MRA compliance,
Oh,
all
fantastic!
these
It's
things.
written by you.
Yeah, yeah, it's
Oh my
mine.
God, this is the book written by you.
Yeah, see, you never read my books. That's the
Ah,
problem.
I never get it. Okay, I'll come to
Yeah,
your office and we'll pick up some.
yeah. But you can pick it up from Amazon
Uh,
and then put a nice review for the books, even if you don't understand it.
we will have a new HBMA live session. This session is just to introduce you to the community, but next session we'll just pick up each book and talk about them, because
Yeah, yeah,
I feel there is a huge amount of there's a huge need for
yeah,
us to be educated in the field what you're talking about, and
yeah,
then and from that understanding and from that uh,
yes,
reading, the opportunities come.
yeah. So we are happy to share what we know.
Mhm,
We are happy to share our expertise. Actually, we have different. We are providing this service for about 5 health plans across the country,
mhm,
and so we have no problem sharing it with you. We have big groups, physician groups, who come to us who want us to do this for them. We have no problems. We'll do that. There are timelines though. So timeline for 2019 is going away end of this month.
okay.
Too late to catch up now, most likely, because to learn it. But
Right.
if you master it, if you next year for 2020, end of January is the timeline, end of January 2022.
Mhm.
So that 1 year window will come to a close. So if you are eager, if you want to learn it, we're happy to share it with you. We're happy to hold your hands until you're big enough. And I think there are enough opportunities in this business and in life to grow with each other and share
That's
our
right. And for fee for service, you see an equal amount of opportunity in fee for value as well for medical billers. That's what you are telling me, and that's what I'm getting at.
if I dare say, the opportunity is bigger because
Bigger.
very few people know fee for value. I mean, see, you've been doing this 20 years, fee for service. You guys are masters at it.
Uh-huh.
You know 10 times more than I know, right? All the ICD 9s, ICD 10s, CPT codes, CPT 1, CPT 2. I can run circles around me. But where this new approach is coming, it has just come, and most people are not, because you're not doing it practically.
Correct.
If you're not doing it, it's only theory. So if it's theory, how are you going to help? And nobody's there to teach you. Health plans are not holding your hands.
Right.
Physicians are getting upset. I see so many affiliate physicians getting angry at
Right.
their biller or coder because
Right.
they missed sending all 8 codes, 16 codes. Now most billers have gotten good with it. They're
Right.
sending 16 codes, 24 codes. But missing stuff on EDPS wraps, looking at the gaps, looking at the denials, who's looking at the MMR files? I guarantee you 1% of billers are looking at MMR files. But I guarantee you 99.9% are looking at the denials that are coming from the insurance companies and refiling, fixing it, right? You're good at it. This is a similar thing, but you have to know what you're looking at. Otherwise, you wouldn't know. I mean, what would you do if you don't know the data, the value of the data? So happy to teach, happy to share. You'll have to learn a few things, basic things, but principles remain the same. ICD 9, ICD 10, whatever, ICD 11 when it comes, those are not going to change. Those are the same principles. Your all your the compliance with the documentation, yes, it has changed this year. How much time is spent? Fundamentals remain the same. You
Right.
just have to tweak that and take a little shift to a different way of looking. It's just a little modeling that has changed. But you guys should be the ideal people to handle it and do it for big practices and health plans.
Absolutely, absolutely. You mentioned to me at some point we were talking about you have a lot of offshore global billers working in India, and you started this auditing of Medicare charts. And tell me something about that process, and probably some of our members would definitely get benefit and get some new ideas about it. How is
That's
it going, and how is it creating more opportunities
yes.
for better reimbursement from Medicare?
So clinical documentation improvement experts, we call them CDIs, and I'm sure
Yeah.
you've heard of them. So here, most of the time, we hire doctors who are coming from other countries, say Cuba or South America, who cannot get a license here. They know the medical terminology, they know the medical conditions, they can help. So I said, let me train people, youngsters who can put more energy, because doctors are still limited. They're going to travel, they're going to go to different offices. Why can't we do it online, and people can look at the charts in a secure manner and suggest codes? So someone has diabetes,
Correct.
right? DM2.
Mhm.
And you write your ICD-10, whatever it's I something something,
Yeah.
right? You sorry if I look sound like what I don't know what I'm talking about. That's all I know, right?
That's what
And
we
then
want. Yes.
next visit in 3 months comes as PVD,
Correct.
peripheral vascular disease. But we know that when we start connecting diagnoses, we get paid more,
Correct.
right?
We think
So
you are you talking about the linking from
linking.
Okay, so CP.
Linking. So
Okay.
the CDIs were trained to start looking through the chart and say, where are you missing the linkage?
Oh, okay, got it. So okay.
Sphenomegaly, cirrhosis of the liver.
Mhm.
Two different codes.
Correct.
But what does it mean clinically? It means portal hypertension. The moment you put portal hypertension, your RAF score goes up by 0.7.
Okay,
Right?
I got it. So we used to we traditionally in the billing system, any billing system, you have that, linking where the doctor who does the charge entry or anybody who does the charge entry, they can link those. But what my understanding is, what you're telling me, you can do this CDI audit later on and refile the claim and get the reimbursement, because
No.
that's okay.
You have to do the audit beforehand.
Before it goes to okay.
So if patient is coming to see me tomorrow, the CDI will review the chart and said, Dr. Singh, you missed it. Tomorrow the patient is coming. Please see if you agree with this diagnosis or not. I may agree.
So they act like you're okay. Good. Your personal assistant, personal biller.
Right. That's right.
Educating you and giving you an opportunity to.
That's right.
Okay.
So if I'm missing something, the cirrhosis of the liver with ascites.
Right.
Cirrhosis of the liver, 1. Number 2, ascites. Why? Why not cirrhosis of the liver with portal hypertension?
Correct.
So cirrhosis of the liver, RAF score is 0.2. Portal hypertension, 0.7. Right? So it is not that the problem is changed. It is how you are documenting and billing for it. Diabetes, nephropathy.
And this is true for fee for service as well, right?
Yeah, diabetes CKD3.
Right.
Why don't you write DM2 with diabetic nephropathy?
Absolutely,
right?
absolutely.
So connecting, and that's the cause. Patient is having proteinuria, albuminuria. Why don't you document it? So that linking is missing. Hypertensive heart disease with CHF and nephropathy. Not many physicians will write it, right? So once you start connecting these, then it suddenly has tremendous value for the physician. And these are completely valid codes. So they will tell me, Doc, you may be missing this. I review the chart. If I agree, I document it. If I don't agree, I say I don't agree. And once it's documented, it goes to the biller standard process. The CDI will review it next day. Did you document it? Did you miss it? If you documented it, check, it's done. If you said no, check, it's the doctor doesn't agree. This diagnosis doesn't exist. Or the doctor missed it. It comes right back to me before I'm completing the note. Doc, you missed it. What happened? Right? Now I have to decide whether if it's something that is diabetes and PVD, I can link them. Or if I fail to document it, I have to bring the patient back and document it. So again, the whole approach changes, and that's what we did.
Yeah, I was actually listening this on YouTube, recent YouTube talk, and it was on managed care, and it was talking about how HEDIS, it used to be HEDIS, and it has converted into what you're talking about, fee for value, and it's going to be more complex in the coming times. So um, I think we are almost 25 minutes. I know you have to go. You were telling me that you had to go, so we'll keep it short this time. But I promise, I want you and a lot of our members, actually, they're watching right now, and it's going to be shared with a lot of people as well. So they want to hear you again. They want to understand the complexities of this billing, and we would love to have you as a keynote in one of our conferences.
No problem.
We have our annual conference coming in September in Dallas. So I invite everybody who's listening, please go to our website, callhbma.org, and check our upcoming conference. Dr. Pariksith Singh,
Thank you.
LinkedIn. Thank you very much. You have any closing notes? Please go ahead.
If you need me to bring our experts, I'll be happy to bring them in the next meeting. You can talk to them, you can communicate with them, and then you can go offline, you can deal with them, and I'm happy to help.
Yes.
Happy to work with everyone.
But thank you, everybody, for watching. Please watch. Dr. Singh is extremely, he's social, and he's available on LinkedIn. So you can reach out to him from LinkedIn, and you can read his article on LinkedIn. Thank you, Dr. Singh.
Thank you.
Everybody.
Have a good one.
Thank you, and we'll see you again.
Okay. Bye.